Hello, everybody, and welcome to the National University Heart Centre Singapore's English Virtual Symposium. So good to have you here with us today. The theme for this year's is Get Connected to the Heart Truth. It's all about the heart truths every year on this symposium. I'm so glad to be back. My name is Daniel Martin from MediaCorp CN8 938. Let's get you connected to the heart truth. We've got great presentations lined up for you today and a Q&A segment. What you can see on the side of your screen right now, it's the live chat function that's running on your YouTube page. Anytime you've got a question, type it in there, leave it in there. We're going to get as many of these questions across to our presenters today as possible. So don't forget, live chat function right next to your YouTube window. Type it in anytime. You can type in the doctor's name or you can leave it open. That's absolutely fine. And don't forget, you're watching it from the comfort of your own home, live at home right now. You can copy and share that link, WhatsApp it across, send it by Facebook Messenger, go share it with your friends and family members right now. Tell them to tune in now live for this edition. Get connected to the heart truths. This is, of course, presented by the National University Heart Centre Singapore, which was set up by the National University Health System, and it was created to meet this growing need of providing care to the increasing number of people in Singapore who are suffering from heart disease. And besides patient care, the National University Heart Centre Singapore's experienced physicians and surgeons also train and nurture the next generation of healthcare providers, passing on their knowledge and their skills. Patient care is backed by leading-edge research from their research teams as well as their research arm, and the Cardiovascular Research Institute, the CVRI is its name. The aim is to advance cardiovascular care and treatment. I've tapped on their resources many times on my television and radio shows. I'm so glad that you get a chance to hear from the experts today themselves. After all, the seriousness of the matter is real. Do you know that 1 in 3 deaths in Singapore is due to heart disease? That's how serious this issue is. That's how widespread this is. It may affect you, someone you know, a loved one. It's that close. Now, as these illnesses have all such serious consequences, it is so important for each and every one of us to be educated and to know when to take the necessary steps and precautions and actions as well. Today, our NUHCS's cardiology experts, they're going to share with you tips and knowledge to maintain and improve your heart health. Let's prevent that issue from happening. We're also going to learn about the treatment options that exist and how it could really make a change in terms of your long-term recovery and outcomes. And as I mentioned early on, there will be the Q&A segment coming up where you're going to get a chance to be a part of this session. Now, don't forget, leave that in the live chat function at the side of your screen. Let's get things started and get connected with the heart truths today. Our first topic is all about the CT coronary angiogram. My guest is the head and senior consultant of the Department of Cardiology at the National University Heart Centre Singapore. He's heavily involved in medical and nursing education. He has a special interest in heart failure and non-invasive cardiovascular imaging as well. And today he's going to talk to us all more about the CT coronary angiogram. I'm excited to learn more about how it can make a difference, how it could help you potentially pick up a problem before it becomes a problem. Let's see if that window of opportunity is there with this technology and with this approach. My guest is Dr. Chai Ping, head and senior consultant from the Department of Cardiology. Dr. Chai, over to you.
Daniel. Hello, everyone. It's my honor to be able to talk to you about CT coronary angiogram. And this is a typical scene from my clinic. And chest pain is actually one of the most common reasons why people come to consult us. And you should not ignore chest pain because it can point to an underlying serious condition. Now, there are many causes of chest pain, ranging from chest wall muscle problems to breast diseases, to the stomach and the lungs. However, I think most people are concerned about coronary artery disease or heart artery disease causing the chest pain. And as you know, heart artery disease results in narrowing and blockage of the arteries and impeding blood flow to the heart. And I think most people also know that coronary artery disease can lead to serious consequences such as a heart attack. As you know, coronary artery disease is a leading cause of poor health as well as death. So now, the coronary arteries or the heart arteries actually run on the surface of the heart. They originate from this big artery called the aorta that supplies blood to the rest of the body. So the coronary arteries actually supply blood to the heart muscles, very important function. There are three major coronary arteries. On the right side, you have the right coronary artery. On the left side, there is this large artery called the left main artery that originates from the aorta and then divides into two branches, the left anterior descending artery that runs down the front of the heart, and then the left circumflex artery that hooks around the left side of the heart. Now, the major cause of heart artery disease is due to this process of atherosclerosis, which is actually seen as a degenerative process of the heart artery. Now, when we were babies, if you cut the coronary artery in the cross section, you see this kind of very nice and smooth artery wall. The artery is actually formed majorly of smooth muscle cells, and of course, inside the artery is the lumen of the artery where the blood flows. Now, by the time we are teenagers or early 20s, fats and cholesterol starts to get deposited in the wall of the artery. So this is an early atherosclerotic plaque, also known as a fatty streak. Now, due to various risk factors such as diabetes, smoking, hypertension, stress, and so on, this cholesterol plaque can build up over time and eventually make the lumen become narrowed and even blocked. So this is the process of the atherosclerosis transformation. Now, for the majority of people, the plaque gets calcified, which means that calcium deposits in this plaque and makes the plaque become hardened. However, in some unfortunate people, the plaque can rupture and the plaque material then enters into the bloodstream and cause a blood clot to form. When this blood clot forms, it will block up the artery instantaneously, and that gives rise to a heart attack. So when you see a doctor with chest pain, the doctor needs three important sets of information. The doctor needs to know whether your symptoms and signs are due to heart disease. The doctor needs to know the state of the blood flow to your heart muscles, as well as the state of your coronary arteries. And this helps the doctor to make the correct diagnosis and to determine the treatment and how urgent the treatment needs to be delivered. Now, so when you go and see a doctor with chest pain, the doctor will ask you a lot more details about the chest pain. And this is important because the doctor can then make a diagnosis whether that symptoms are due to underlying heart condition. Now, some of you may have undergone a stress test like this lady reporter from America. A stress test is basically a test designed to look at the state of the blood flow to the heart muscles. But of course, we also need to look at the state of the heart arteries, and we do this by performing a procedure called a coronary angiogram. The word angiogram means picture of a blood vessel. So how do we perform coronary angiogram? There are two general ways. One way is to insert a tube into the heart, into the coronary arteries, and then we inject a dye, or also called a contrast medium, into the arteries. And then we do x-rays, and that will show us the arteries and whether there's any blockage or narrowing. But that, of course, is an invasive procedure, and it does carry a small risk of complications such as bleeding. Another way is to do what we call a non-invasive coronary angiogram, and we can do this using MRI scanners or a CT scanner. So of course, I'm going to talk to you about CT coronary angiogram. So what do we require to perform a CT coronary angiogram? Of course, we need the scanner. The CT scanner basically is essentially an X-ray tube that sends X-rays through the body of the patient. The patient is lying in the center of the scanner. And these X-rays are then detected by an array of detectors opposite the X-ray tube. So when the body passes through the X-ray gantry, the tube goes round and round and round to take pictures of the region of interest. In our case, of course, the heart, right? So this will then be processed by the computers to give you the images that we required. Now, for CT coronary angiogram, we also need to inject a dye or contrast medium. And this dye is what we call radio opaque. It blocks the X-rays and therefore highlighting those structures in which the contrast flows. Now, of course, we also need a patient. We will need a radiographer to operate the machine. We need a nurse to monitor the patient. We will need powerful computers to post-process the images, the data to give us the images. And then we will need a radiologist to interpret the images. And finally, your cardiologist will then take those images and the report and decide what to do for you. All right? So this is a typical image from a CT scan, and you can see that this is the heart in the middle of the chest, and the dye has entered into the heart chambers and the aorta. So you see the white areas in the middle, that is the heart chamber where the dye or the contrast medium has entered. Now, so this dye blocks the X-rays, and so the computer will post-process it and turn the picture white. If the X-rays passes through the body easily, such as through the lungs, the picture is black. Okay, so you can see the lungs are black here. All right, so now the good thing about modern scanners is that the scanners acquire a three-dimensional volume of data, and this can be reconstructed into a picture that looks like this. And this allows us to look at the heart and the coronary arteries from various directions and angles so that we can detect all the atherosclerotic plaques and assess the narrowing and the blockages. All right? So now, it is important to know that there are 4 important sets of information that we can obtain from the CT coronary angiogram, and I'll go through these 4 sets with you. So the first thing that we do when we put the patient in the scanner is that we take a plain CT scan first without injection of the dye. So in this plain CT scan, some of the tissues such as your coronary arteries will block some part of the X-ray, and therefore the coronary arteries, which is arrowed here in green, will appear as gray. All right? And this pictures of a patient with normal coronary arteries. Right? Now, if the coronary arteries have calcified plaques, then you will see this, because the calcium will block the X-rays, and then the computer will then display the calcium as white. All right? So this is a patient with a lot of calcified plaques. And this is important information because the amount of calcium is a direct indicator of how much atherosclerosis has occurred and the extent of atherosclerotic plaques in the coronary arteries. So the computer can then calculate a score. This is called the coronary calcium score. And this score is very useful for us to help us to predict future risk of heart attack and death from heart disease. So there have been multiple research and studies that have been conducted over the last 30 years or so, and this is one example of a study. And you can see from this graph that the more coronary calcium, the higher the calcium score, the higher the risk of future heart attack and death from heart disease. Now, on the contrary, if your calcium score is 0, the risk of heart disease is very low, okay, exceedingly low, less than 1% over the next 5 to 10 years, all right? So now when the dye is injected and the contrast of the dye enters into the coronary arteries, then the lumen of the arteries will show up as white, as seen here. These are pictures from a patient with normal coronary arteries, and you can see that the wall of the artery is very smooth, and there's no narrowing or obstruction of the coronary arteries. Now, as opposed to this particular patient, you can see that there is a little narrowing there in the middle of the artery. This is the left anterior descending artery. This is caused by an atherosclerotic plaque. All right? So visually, you can take a look at this picture and you can say that the narrowing in that segment looks to be about 50%. All right? So narrowing in medical terms is known as stenosis. So we would call this moderate stenosis. Now, of course, we don't really always rely on our eyeball to estimate the degree of stenosis. We have computer softwares that can allow us to estimate or calculate the amount of stenosis. So in this particular patient, the computer gave us a value of 52%. So that is actually quite close to our visual estimation, right? So now these are examples of patients with more severe stenosis. You can see how narrow now that segment of the artery is. And another picture here of a patient with very severe stenosis. And we can also view the stenosis from outside the heart. This is what we call a three-dimensional volume rendered image of the heart. You can see that very thin area where blood is just trickling through, all right? Another patient with severe stenosis, here the artery is almost occluded, and this patient had chest pain, so he was sent to our cardiac catheterization lab and he underwent invasive coronary angiogram. And now you can see where the artery is blocked. That corresponds to what we see on the CT coronary angiogram. So this patient, of course, underwent ballooning and stenting, and now you can see the blood flowing down the artery when the artery is opened up, all right? So this is where CT coronary angiogram is very helpful to non-invasively help us to diagnose the presence and the severity of coronary artery disease, all right? Okay, we can also use CT coronary angiogram to assess stents. This is an example of a metallic stent. The metal in the stent will appear as white, okay, on the CT picture. This is an example of a previously implanted stent. We used to implant this, what we call a bioabsorbable stent. The stent material will get dissolved over time, and that leaves behind two little, what we call platinum markers to indicate the location of the previous stent, all right? In this case, the artery is open, all right? It's patent. Now, we can also use CT coronary angiogram to evaluate patients after bypass surgery. So in coronary artery bypass, what the surgeon does is to take the veins from the legs or some arteries and connect to the aorta and connect to the distal part of the coronary arteries to bypass the blocked or the narrowed segments, all right? So here you can see this patient with three patent coronary artery bypass grafts, all right? One on the right side, one coming down from the chest and connected to the left anterior descending artery, and another vein graft that connects to a branch of the left circumflex artery. So in this particular patient, all the grafts are patent. Now this patient, unfortunately, is supposed to also have three grafts, but unfortunately, the graft on the right side is blocked. So when it's blocked, there's no contrast flowing through, and therefore the graft does not show up on the CT scan. And that leaves behind a little stump on the aorta as indicated by the red arrow, and that stump indicates where the graft was supposed to be. The other two grafts in this patient are patent, all right? Okay, now besides atherosclerosis, there are some other abnormalities of the coronary arteries that the CT scan can pick up. So some patients are born with coronary arteries that originate from the wrong place, all right? So in this particular patient here, the right coronary artery comes out from the left side when it should be coming out from the right side, okay? So some of these patients do get into trouble in terms of chest pain as well as heart attack, particularly when they do strenuous exercise, all right? Here is a patient with an abnormal dilatation or enlargement of the artery, and this is called a coronary artery aneurysm, all right? And these aneurysms can also give rise to heart attack and chest pain because sometimes blood can clot within the aneurysm. So besides looking at the coronary arteries, the CT scan can also tell us about other heart abnormalities. For instance, this particular patient has a very large hole in the heart. And you can see where the arrow is pointing, that hole there. And now contrast and blood is flowing from the left heart chamber into the right heart chamber. That's not supposed to happen, all right? So this is a hole in the heart. Another example here is a patient with a metallic valve. As you can see that bright starburst pattern, that's the metallic valve. And then there is a black object in the heart chamber. That's a blood clot. And this is a very dangerous situation because the blood clot can then block up the heart valve, and then the patient can experience sudden cardiac death, all right? Okay, so besides looking at the heart and the coronary arteries, the CT scan will also pick up certain abnormalities outside the heart because we can see the chest, we can see the lungs, the liver, and so on. And here is an example of a patient who incidentally the CT scan picked up a little nodule in the lung. This could very well be an early lung cancer. So this patient will definitely needs to be followed up closely, all right? Another example here is a patient, a lady with part of the stomach in the chest, all right? This is called a hiatal hernia. This is called a hiatal hernia, and the stomach is not supposed to be in the chest, it's supposed to be in the abdomen. So when the stomach is, in the chest, it can cause chest pain and indigestion and so on, all right? So who is eligible for CT coronary angiogram? we can use CT coronary angiogram to evaluate people with chest pain or shortness of breath suspected to be due to coronary artery disease, but not when the patient is suffering from a heart attack, okay? We also use CT scans to evaluate people with suspected coronary artery anomalies, as well as people with equivocal stress test results, basically to find out whether there's underlying coronary artery disease. However, CT scan does have some limitations. Principally, of course, there's radiation exposure because of the X-rays, and the contrast of the dye is not suitable for people with moderate to severe kidney disease because the dye can actually damage the kidneys, all right? It is also not suitable for people with fast and irregular heartbeat, as well as people who can't hold their breath, because then you get motion artifacts and then the pictures become blur, okay? Just like when you take a picture and somebody is moving. So we are looking forward to some future developments of the CT coronary angiogram. In the future, hopefully we can get all these images with less radiation at higher resolution so we can see all the smaller branches, as well as faster scans so that we can scan with just a single heartbeat, all right? And then of course, in the future, we can have this ability to measure blood flow in the coronary artery as well, so that we don't have to do the stress test anymore. So ladies and gentlemen, in conclusion, CT coronary angiogram is a very useful non-invasive test to help us to determine the cause of chest pain, and it is able to help us to risk stratify people for treatment, as well as to accurately determine the severity of underlying coronary artery disease. And finally, it can also provide information about other heart and non-heart conditions. Thank you very much.
Dr. Chai, that was fascinating to see the amount of detail and what is actually shown in those images. I'm sure many people wonder, though, they're afraid of doing the CT scan. They're afraid of going down that tunnel in a bit. Yes. It's done very quickly, isn't it?
The entire scan takes probably about just 10 seconds.
10 seconds, that's all. Wow, fascinating. I hope you enjoyed seeing those actual images and seeing the power that this kind of scan can actually have for you. If you've just tuned in, thank you so much for joining us right here at Get Connected, the Heart Truths. One thing I love about watching these symposiums online like you are in the comfort of your own home right now, you know when we have seminars and forums in like a lecture theatre or a hall, people are like rushing to take photo of the slide. No need, you can watch it back anytime. You can rewind and scrub and watch. You didn't have to take photos this time around. Thanks for being here, everybody. Let's move on to our second speaker at today's event, and we have to zoom in on the huge issue of heart failure. My guest is a consultant at the Department of Cardiology at the National University Heart Centre, Singapore, where he specializes in the management of acute heart failure and is active in clinical research and medical education as well. Today, diving into the topic of heart failure and how it affects all of us really at the end of the day through either yourself, your own experience, or people that you might know who are having it. Sharing more about the latest treatment strategies that can really make a difference. Dr. Lin Wei Chin joins us. Dr. Lin, over to you.
Thank you, Daniel. Thanks everyone for joining us today. We are going to learn a little bit more about heart failure, what exactly it is, and what are the treatment options for patients diagnosed with heart failure. So this is the content of my talk today. So we are going to define the condition called heart failure, how common it is in our current society, what are the causes of heart failure, and how we as cardiologists diagnose and treat heart failure. And most important of all, for patients who have heart failure, what are the outlooks for them, and for patients without heart failure, how do we prevent heart failure? So what is heart failure? That is the basis of everything that we need to talk about today. So heart failure is a condition when the heart is unable to perform its function of circulating heart around the body in a sufficient manner. So the heart, if we think about it, is a muscular pump. Its primary function is to circulate blood to all the active organs in our body to meet its metabolic needs. So if in a patient with heart failure, this process is impaired, there is not enough circulation, and patients eventually will develop symptoms of heart failure. Heart failure is a clinical syndrome, meaning we cannot use a single test, a blood test or a scan to diagnose heart failure. This is not like cancer where we can do a CT scan and we take some cell samples to diagnose cancer. No. Heart failure requires more than that. So doctors need to speak to the patients, get their symptom history, and perform a very thorough physical examination. With this suspicion of heart failure, then we will need to move on to some specialized investigations to confirm the diagnosis of heart failure. So this is what we mean by a clinical syndrome. There's no one test that can be easily used to diagnose heart failure. So when a patient has heart failure, what are the typical symptoms that the patient can expect to feel? The most common thing that they often tell us would be effort intolerance. What does that mean? So effort intolerance means a worsening of his exercise capacity, exercise capability. Many of my patients tell me that they used to be able to walk 2-3 bus stops without any major issues. After their onset of heart failure, they find it even very difficult to complete half a bus stop. To get to 1 bus stop, they need to stop 2 to 3 times. That is what we mean by effort intolerance, and they can present as breathlessness, commonly breathlessness, or patients can just feel very tired when they walk the distance. Then there is also a very common symptom called atopnia or inability to lie flat. Heart failure patients have very, very sensitive lungs, so when they lie flat, the lung pressure actually increases and they feel extremely uncomfortable, and some patients describe to me as if they are drowning in their own breaths. So that is what many heart failure patients describe to us. And of course, with the heart being very poor, there's poor circulation to all the major organs, including the intestines. Patients often have loss of appetite. They are very hungry, but they are not able to eat much. Small amounts of food make them very nauseated. So that is a common complaint that we have. Eventually, these patients will develop signs of heart failure, meaning they'll see water retention, they'll see fluid in their lungs, they'll see fluid in their legs and their tummy, and in severe cases, they might even have low blood pressure, feel dizzy, and faint from that. So these are the kind of symptoms that my patients often tell me. But how common is this condition? So from a study done about 5-6 years ago, we find that 4.5% of Singapore's population actually at this point in time is living with heart failure. That is a huge number if you compare to other countries like the US and in Europe, where the population prevalence is about 2%. We are having twice the number of heart failure patients in our population. And this is not a trivial diagnosis. Half of patients after diagnosing heart failure die within half a decade, 5 years. That is worse than many cancers that we know of today. So what are the causes of heart failure? My previous speaker, Dr. Chai, talked a lot about ischemic heart disease, and indeed, ischemic heart disease is one of the major causes of heart failure in our population. We used to lose a lot of patients after heart attack. They die because of inadequate treatment, but with advancement in heart attack treatment, many patients survive heart attack, but the long-term consequence would be that of heart failure. Other causes would be high blood pressure, alcohol intake, and increasingly we are also seeing the success of our cancer treatment. Patients in the past die from cancer, but nowadays they survive cancer because of chemotherapy, but in the long run the chemotherapy can actually cause heart failure. And lastly, a small group of patients have heart failure running in their family. These are the rarer genetic or DNA causes of heart failure. So consequences of heart failure, of course, when the patient develops heart failure, they get symptomatic. They have recurrent episodes of breathlessness and water retention, and because of that, they keep coming in and out of the hospital. They have poor effort tolerance. They are not able to perform their day-to-day work or tasks easily, and they get depressed or they get very dejected because of that. Of course, in a patient with very weak heart, there's always a risk of sudden death. They can suddenly collapse because of the heart just stopping unexpectedly. In other patients without this kind of sudden death situation, they might get worsening heart failure and they have end organ dysfunction. They can go into multi-organ failure and they die prematurely. So how do we diagnose heart failure now that we know it's such a serious condition? So as I mentioned, heart failure requires an in-depth history taking and physical examination. The examination findings are usually as such. We can see distended neck veins in patients with heart failure. When we listen to their lungs, we can hear lung sounds. We look at their legs for leg swelling, and we often detect abdominal water retention. The medical term for that is ascites. Specific investigations after we suspect the diagnosis of heart failure would include all this. So not everyone goes through every single investigation. The cardiologist looking after the patient will pick the best investigation for the patient to make the diagnosis of heart failure and potentially treat the underlying problem to improve the heart failure. Common tests would include electrocardiogram, a chest x-ray, echocardiogram, and maybe in some situations a coronary angiogram. Some specific blood tests are also important for us to help improve the outcome of patients with heart failure. So this is an electrocardiogram, an ECG. This is a normal, completely normal ECG. Compare this to a patient with heart failure. There are some subtle signs on this abnormal ECG that can point to the diagnosis of heart failure to the trained eye. An X-ray is often used to diagnose heart failure. So on your left side is a normal X-ray where we see black colored lung fields. The heart looks pretty small, not too enlarged. If you compare that to the X-ray on the right side, the heart looks big, the lung is not nice and black, there are patchy white things in the lungs, and those are water retention signs in the lungs. So that is a typical X-ray that we see of a patient with heart failure. An echocardiogram is one of the most important tools that we have for the diagnosis and the treatment of heart failure. It's a non-invasive ultrasound examination. There is no X-ray radiation involved, and it allows for quantification of this pumping function of the heart. If you look at the movie on the right side of the screen, the top two chambers of the heart are called the ventricles. They are responsible for pumping blood to the lungs and to the major organs of the body. They are pumping very well, and in this situation, the ejection fraction or the pumping function of the heart is about 60%. A normal heart pumping function will be in the range of 55 to 65%, so this is an absolutely normal echocardiogram. Of course, when we do an echo, we can also look for other causes of heart failure, such as valve dysfunction. If you look at the echocardiogram on the right side again, there are little leaflets that we can see separating the top and the bottom chambers of the heart. Those are heart valves, and if they are dysfunctional, they can lead to heart failure, and an echo can tell us this information. Of course, there are some people who are born with abnormally thick heart muscles. They can also be the cause of heart failure. Contrast the normal echocardiogram we see here to these two echocardiograms. The one on the left side is someone with a very weak heart pumping function. We call it reduced ejection fraction heart failure. The heart pumping function in this situation would be in the range of 15 to 20%. Contrast that to the previous echo from the previous slide where the heart is pumping at about 55 to 60%. It's very obvious in this case that with this kind of weak heart, the patient is going to suffer from a lot of symptoms of heart failure. On the right side of the screen, we can see an echo that is not exactly normal, but we see that the pumping function of the top two chambers of the heart, they are pretty okay. This is what we call preserved ejection fraction heart failure. These two different classes of heart failure are very important for us to identify, because the reduced ejection fraction heart failure is the kind of heart failure that we traditionally treat, and there are good treatment options for that. But for preserved ejection fraction or preserved pump function heart failure, this tends to occur in elderly women, in patients with kidney disease, and up to today, not many good treatment options are available for this group of patients. So of course, when we talk about heart failure, then what's next? What after the diagnosis of heart failure? Treatment options, there are some, but the most important thing starts from within. So patients diagnosed with heart failure, they really need to make a conscientious effort to change their lifestyle. They need to modify diet, they need to reduce their salt intake, and this can reduce the chance of them having symptoms of heart failure. Smoking cessation is important, as with most other heart diseases, and of course they need to get active. Some people after diagnosis of heart failure, they feel that they can't do as much as the past. They would try to not walk around, sit around for fear of triggering symptoms. That is the wrong mindset. If you have heart failure, in fact, exercise can improve heart function and reduce the chance of getting hospitalized for heart failure symptoms. Medications remain the mainstay for treatment of heart failure. As I alluded to just now, patients with low ejection fraction or low pump function heart failure, the boxes in blue are the standard treatment nowadays for them. So there are generally four classes of drug useful for the treatment of patients with low ejection fraction heart failure. Group 1 and Group 2 are common drugs that we often use for patients with high blood pressure. In this situation, in patients with heart failure, they are not exactly targeting the blood pressure. These medications can improve the pump function and can reduce the chance of patients dying. The third class of medication, the mineralocorticoid antagonists, they are a kind of hormone blockers which can also help patients reduce fluid retention. And the last class of drug called the sodium glucose cotransporter 2 inhibitor, or SGLT2 inhibitor, is a new tool that we have over the past couple of years. We find that this group of drugs, which used to be diabetes drugs, now can be used in heart failure patients with low ejection fraction, and they can reduce the chance of hospitalization and can make patients live longer. So the blue boxes are very, very important. They prevent death, they prevent hospitalization for patients with poor pump function. Other adjuncts that we use include the very common water pills. We give patients these water pills to expel excess water, improve their symptoms, allow them to lie down to sleep without drowning in their own breath. Oops, sorry about that. The next step, for suitable patients, we often send them for evaluation of the coronary arteries. Most of the time we go direct to a coronary angiogram. As Dr. Chai mentioned just now, coronary angiogram allows us to look at the coronary arteries. In a patient with severe coronary artery blockage, the heart muscles are chronically starved of oxygen, and it's not surprising that they get very, very weak because of low blood flow. If we can reverse that, if we can put a stent, or if we can do a bypass surgery to improve the blood flow, there is a very good chance that the patients with poor heart function can improve their heart function, and that's what we hope for all our patients. However, for some patients, despite medication, despite putting in stents or going for bypass surgery, the heart function continues to be bad. So in this group of patients, they are at the risk of suddenly collapsing and dying, and we have a useful tool for this group of patients. We call them the electronic devices that we can implant inside the heart. So this group of devices can prevent death by delivering a shock if the heart goes into abnormal rhythm, dangerous rhythm. And some patients with dyssynchrony or abnormal pumping synchrony of the two heart chambers, we can use wires to improve the pumping function of the heart, and patients can feel better, and there's a chance that the heart function might improve in this group of patients. And of course, for patients who are yet to develop heart failure, we hope never to treat them for heart failure. So the primary prevention of heart failure is important. Since coronary artery disease is one of the main causes of heart failure in Singapore, the main prevention of heart failure would involve the prevention of coronary artery disease. So as I mentioned before, smoking cessation, avoid excessive alcohol intake, regular exercise, and healthy diet. So if we adhere to a healthy diet recommendation by HPB, that will be very, very helpful for us to adopt in our daily life. And of course, for patients more than 50 years old, even if you are healthy, we should go for regular health screening, looking at cholesterol levels, sugar levels, and blood pressure. So in conclusion, heart failure is an increasingly common condition in the Singapore population. 4.5% of the Singapore population is actually living with heart failure. Heart failure is a clinical syndrome that requires close examination by the cardiologist together with specialized investigations to come to the diagnosis of heart failure. And once the diagnosis of heart failure is made, many hospitals have multidisciplinary teams taking care of patients with heart failure, going from lifestyle modification, medication treatment, as well as in some situations device implantation. And of course, as I mentioned last slide, the primary prevention of heart failure, preventing coronary artery disease, is very important to prevent downstream complications of heart failure. So I thank you for your time.
Dr. Lin, thank you very much indeed. I love that there was such an important message of taking charge of our own health there, and how changes that we make to our lifestyle could have an impact on heart failure. But a quick point I just want to touch on, you mentioned that 4.5% of the population living with heart failure. Is the problem the fact that some of us we associate these symptoms as a normal part of aging and that we'll just live with the symptoms, or is it because of some other factors here?
I think there's still general lack of awareness of this condition. Heart failure sometimes can be very, very subtle. Patients can feel lethargic, they can feel short of breath, and many elderly patients tend to brush it aside, saying that maybe I'm just getting old. Actually, there is something wrong with their heart, and potentially, if we pick that up, it's treatable.
Thank you very much. Now you're connected. That's what today's session is all about. Get connected to the heart truths. Now you're aware a little bit more about heart failure, about CT coronary angiograms. If you have questions about those, leave them in the live chat function of your YouTube feed right now as we continue with today's session. Imagine, early on you saw the images from Dr. Chai, the idea of those blocked arteries. Imagine being able to go in and to clear that blockage, to open it up all again. That's what balloon angioplasty has been doing for a very long time, and it's come a very long way indeed as well. My next guest is a senior consultant from the Department of Cardiology. You'll often see him participating in the international cardiology conferences as a speaker. He has a personal column in the local press as well. I've had the pleasure of interviewing him many times on my TV and radio shows as well. Today he's going to introduce all of us to the idea of the balloon angioplasty. You're going to learn about how this treatment has evolved. Maybe one day you might need it. Maybe a loved one has had it already. Stay tuned. Learn about this right now. Please welcome Professor Tan Hui Chin. Off to you, Professor.
Thank you very much, Daniel. So what is coronary angioplasty? Well, sometimes we call it percutaneous coronary intervention, which is PCI. So it's really a procedure performed to open up a clogged artery. So why do I care about this history? It is said that because if you don't know history, you're like a ship sailing in the ocean. You don't know where you come from and you don't know where you're going. Let me tell you that coronary angioplasty in the last 40 years has been a real journey of human ingenuity and creativity coupled with advanced bioengineering feats. So this is where I'm going to take you through this exciting journey. And the story begins with this gentleman called Dr. Andres Granzitz. So he has this idea of opening up a blocked artery using some kind of a balloon. He got his idea from some of the animal work that was done, and that at that time it was thought to be a really out of this world idea, and many people warned him against doing such a procedure on a human being, but he said nothing is going to stop me. So he actually spent about 4 years of his life working in his kitchen table, trying to formulate and come up with this new design of a balloon. So you can see that the first idea was rather primitive, and then it sort of slowly evolved as it go along. And so he was very much supported by his wife, Michaela Granzig. So in 1977, after many years of trying out this new balloon design and actually working out on the animal model, he finally applied it on a human being. And so on the 16th of September 1977, if we look at this particular waveform here, as he inflated the balloon during the procedure, suddenly there was no blood pressure across the artery. And that really tells us that this procedure does work in terms of blocking up the artery at a point in time. And so this is a feat that was accomplished not by an accident, but after an intensive work of 7 years in his lifetime. So he performed the first angioplasty in a human being called Adolf Bortman way back on the 14th of September 1977. He wasn't sure about the result, so 2 days later he brought the patient back again and repeated the angiogram, and the artery still remains open. So he decided, wow, good. Then 1 month later he brought the same patient back again, repeat the angiogram, the artery was still open. And 10 years later he brought it back, the artery was still open. So he knows that this is a procedure that has a result that is sustainable. Unfortunately, coronary artery disease is a progressive condition. It doesn't mean that I open up your artery, now you cannot develop disease later on. So indeed, this gentleman, 23 years later, has got another narrowing, which is not at the original site of narrowing and that requires coronary stenting. But he actually underwent a multiple stenting procedure, and at the age of 82 years old, when he had first his angioplasty at 38, he's still alive and well. So in Singapore, we started balloon angioplasty way back in 1984, and so this was the initial setup in Singapore. But in 1985, unfortunately, Dr. Andre Granzit died. He died in doing something that his he enjoyed doing, and that is flying his aeroplane. In the same year, 1985, a number of angioplasty luminaries also passed on. So that was kind of a dark era at the time for him, for us. But balloon angioplasty is not a good enough treatment, because when you do a balloon angioplasty, the artery is likely to get blocked again. And oftentimes within 6 months of the procedure, 40% of people will get re-narrowing of the artery again. And that is not good. Also, when you do a balloon angioplasty, there's about 4% of people that may suddenly develop heart attack and collapse because the artery can suddenly close off in what we call an abrupt closure. So then we enter into a second revolution of coronary angioplasty, which is the introduction of coronary stent. Now, the development of coronary stent is the whole idea here of implanting a scaffold that will prop the artery open and allow the blood to flow normally. So we don't care what happened to the artery wall, we just care if the artery flows normally. And so many people work on this concept of stenting at about the same time. But in 1986, Dr. Puer and Dr. Seward implanted stents for the first time in human beings at about on the same day at different cities in Europe. One in Toulouse, France for Dr. Puer, and the other one is in Lausanne, Switzerland. So we can't figure out who is the first man to implant stent. But anyhow, following the implantations of the first stent in Europe 20 years later, and this lady, she appears very well again. So stenting has thus offered even more sustained and more effective results compared to balloon angioplasty. What is happening now is that stenting now reduces the chance of an artery getting blocked again from a 40% with balloon to now about between 10 to 20%. So this is a significant leap in terms of results. But the first generation stents was very poorly designed, was very difficult to use. So this is the next stent that come on, which was kind of close to what we are looking at in the present days. But stenting, like I say, has still got a problem, and that 10 to 20% of people develop re-narrowing. So if you look at this particular picture, this is an angiogram done after a stent has been implanted. But 6 months later, you can see that there is a re-narrowing of the artery, and that flow of the artery now becomes narrow. So this is what we call in-stent restenosis. And in-stent restenosis occurs not because cholesterol and fat has deposited once again inside the stent, but because of a scarring process. You see, when you put in a stent in a person's artery, you actually damage the inner wall of the artery, and the natural response is for the wall to heal itself. And with some people, they heal by forming excessive scar, and this is what happened here. So you have excessive scar formation called intimal hyperplasia, which results in re-narrowing of the stent. So how do we stop this scar formations from happening? And this is where the third revolutions of coronary angioplasty come on in. By actually coating the medicine, coating a certain types of medicine onto the surface of the stent, we can potentially stop this scar cells from forming. And this is what we call a drug-coated stent or drug-eluting stent. Eluting stent means the drug is gradually being released from the surface of the stent. So that is the third revolution. In 2000, this was first performed in about 45 patients in Brazil, and this was actually presented in the European meeting in that year in 2002. And the use of a drug-eluting stent, when presented in that particular meeting, showed that there was 0% of re-narrowing. Can you imagine? There was not a single patient that came back with re-narrowing of the stent in that 238 patients that were studied. And from presenting these results, there was a standing ovations in the entire crowd at the meeting. So it was a very, very touching moment that drug-eluting stent was introduced. And this is how a modern stent would look like now. Modern stents now are very flexible, they are very trackable, they are low profile, they are very safe, and they are very easily deliverable. So this is how we have come across. And so how effective is the modern stent? So we can't expect it to be really 0%. But just looking at one of the results that we published from NUH of about 800 patients, we received one type of new generation stent. If you look at here under stent thrombosis, which is blood clot within the stent, it was only 0.4% at 1 year of follow-up. The number of people who develop a heart attack after putting in this new generation of stent is only 1%. And the chances of people requiring a repeat procedure because of a re-narrowing of stent is only 1.3%. So this is the sort of result that we are already expecting in the modern drug-eluting stent. And so one of my patients wrote me this poem, He said, a tiny little stent, only a millimeter or two wide. How wonderful you have been to get me back to life by keeping the channel open to my heart. Who would have thought of this? A little coil wire could do the trick. Hope you keep on doing the job, else I go under the knife or to heaven. So that is the power of coronary stent. Then we're still not happy. We went into this fourth revolution called the bioabsorbable stent. If I can put in a scaffold, not a metallic stent like what we are using right now, put in a plastic stent, and then the stents do its jobs of keeping the artery open and then disappear. That will be even better still, isn't it? So it's what we call the bioabsorbable stent. So the whole concept here is that we will do the same thing here, implanting a stent into a patient's
open clogged heart arteries.
And this is the
bioabsorbable stent
showing
with the
it.
same drug as Abbott's
And
Science
you can see
V
that
stent
the plug
is inserted
there,
into the
so
coronary
stent goes
artery
in,
mounted on a balloon.
It's expanded.
The balloon is inflated to reopen the blocked vessel.
So you take out the balloon, and the stent release the medicine,
Drugs
keep
on
the artery
stents are
open,
designed to
and
prevent
then it slowly
inflammation
disappear on its
and
own.
to prevent
The first patients to receive this bioabsorbable stents in Singapore was an NUH. This was in the year 2011. And so she received this bioabsorbable stent. 2 years later, we brought her back again. We do a special imaging, and we actually showed that the stent and scaffold, or as we call it, disappear. But unfortunately, this bioresorbable stent does not seem to perform as well as a coronary metallic stent because of the higher incidence of blood clot formation. So this has somewhat been put on a hold, but I don't think this is the end of bioabsorbable stent technology that we are looking at. But I think the best part of a coronary angioplasty procedure is actually treating a patient with heart attack. And this was actually started in 1980. Dr. Grunzig himself was so scared of doing this procedure, even himself in the patients with a heart attack. As you know, heart attack is caused by a blockage of the artery. It's an American colleague and a friend of his, Jeffrey Hustler, who attempted this first angioplasty of a patient with heart attack, and how this has really changed, because now emergency coronary angioplasty for heart attack is the standard treatment procedure for patients. So heart attack is caused by a plaque that's been ruptured, causing a clot formation, choking up the artery. By opening up the arteries, you immediately, in a 15 minutes or 30 minutes procedure, abort a heart attack, and you change the person's destiny permanently. And so this is a 24-hour service that is offered in many hospitals around the country, but NUH is, of course, one of them. But we actually have this Western STEMI network, which is called a Western Heart Attack Network, where if you are a resident on the western side of Singapore and you pick up a telephone and you call an ambulance, you suspect yourself to have a heart attack, the ambulance medic come to you, they do an ECG on the spot, and they diagnose heart attack, you will bypass all the other hospital and go straight to NUH for treatment. The reason is because we have decided that we will consolidate all the best resources in terms of equipment, in terms of expertise, in terms of our surgeons available to actually run this emergency heart attack service alongside with the interventional cardiology. And we are doing about 550 cases a year, and this service never stopped, even at the height of COVID. So we will don the PPE and we'll do the procedure as it is even now. But we're not happy with just doing emergency angioplasty, because when you have a heart attack, you have a 10% chance of dying, even with all this best treatment that's been rendered. There's a group of patients with cardiogenic shock, which is the most severe form of heart attack, where you have low blood pressure and so forth, that needs special care here. And this is where NUH want to evolve itself to be a cardiogenic shock center, where if you have somebody with advanced heart failure as a result of a heart attack, we can put in special devices to support the heart as we do the angioplasty emergency procedure. This is one of example called the impeller mechanical circulatory support, where you actually put a tube into the artery and you suck blood out from the heart and pump it to the rest of the body. But we also have another armamentarium up in our sleeve, and that is the ECMO. This is really quite famous because of recent use in NUH. Essentially, what happens here is that you have a machine that sucks blood out of the vein, we infuse it with oxygen, and then we pump it back to the body again. So this is like a bypass pump, so to speak. And this pump ECMO service is made famous because even during the COVID time, when you have patients with severe pneumonia from COVID infection, ECMO team is still in operation and help to save these two lives here, Mr. To and as well as Madam Choi, so making very incredible stories of survival during this COVID pandemic. So how often is PCI being done in the world now? Now easily we are looking at about 4 or 5 million procedures being done in a year, and about 8,000 of such procedures being done in Singapore. And so if you look at the entire evolution of coronary angioplasty from the early 1970s to now, you can see that the chance of failure is very low. We don't even need surgeons to stand by nowadays for the procedure, unlike the past where we always had surgeons keeping an OT open just in case things happen. The chance of re-narrowing has dropped significantly. Chance of blood clot formation has also dropped, and then so forth. So we are now looking at the time where you possibly have the best results of coronary angioplasty and stents in modern time. So I started angioplasty learning in 1994, and this was set up in NUH. 27 years later, we are now in a really high-tech setup here, where now we are looking at much better outcomes for patients in terms of both efficacy as well as safety. So what is for the future for coronary angioplasty? I would imagine that in future, maybe another 10, 20 years from now, there will be no artery blockages that cannot be unblocked. You probably have more effective stents with zero re-narrowing. You have a safer stent that will have no heart attack risk. And hopefully we'll have truly a disappearing stent that will perform just as well as the current metallic stent. So Andres Granzit's famous words before he died was, whatever becomes of the method, I have left one mark on medicine. I have shown that men can work therapeutically within the coronary arteries themselves in the face of an alert, comfortable patient. So this has been the story of coronary angioplasty. And I like the quotes from Confucius. He said, the greatest glory is not in never failing, but in rising every time you fall. And indeed, coronary angioplasty is really a story where human beings endeavor to make us a coronary artery a treatable condition. Thank you very much, and I'd like to pay tribute to my fellow colleagues who are still at the front lines of battling COVID pandemic.
100%. Professor Tan, thank you so much. Phenomenal and tremendous to see that something so small and minimally invasive can have such a huge impact. Just a quick point, I'm sure even after the decades of data and experience and evolution of this procedure, I'm sure you still get patients asking you, is it safe to leave a foreign body in my body or not? Mm-hmm. And what's the answer to that?
Well, the data shows that it is safe.
Yeah. Yes. So we can dispel that notion. Mm-hmm. We've seen that the current generation of stents that you use, you could live your whole life with it, no problem.
That's right.
Good to hear indeed. Any questions about the balloon angiogram? Leave it now in the YouTube chat function. We'll get to the Q&A segment just ahead. I've learned, and we're going to learn today, how there's actually been a long history of pediatric cardiac surgery at NUH. And up next, we're going to learn about the treatment of congenital cardiac problems through surgery. Our guest is going to talk to us about congenital heart disease. The idea of today's seminar, getting connected to the heart truths. We've talked about heart conditions affecting young, middle age and above, and now the very young as well. Neonates, newborns, unfortunately. Did you know that one neonate in every 145 births is probably dealing with congenital heart disease? But the advancements that we have seen in terms of treatment and surgical options has really made a difference in terms of making sure that that newborn lives into adulthood. Joining us on today's edition is Associate Professor Laszlo Kirali, who's a senior consultant from the Department of Cardiac, Thoracic and Vascular Surgery at the National University Heart Centre, Singapore. Here to talk to us about the current therapeutic possibilities and outcomes in congenital cardiac surgery. Professor Laszlo, over to you.
Thank you very much, Mr. Daniel. Welcome to the symposium, and I'm privileged to speak about the current therapeutic outcomes and possibilities in pediatric cardiac surgery. First, I would like to talk about a little bit about what pediatric cardiac disease, congenital heart disease is about, and highlight some demographic data and the surgical possibilities and the current outcomes and some future expectations. So how come that congenital heart disease come to the scene? That's dedicated to the heart's development, and the heart is the first organ in the body that actually starts functioning at the third week of gestation, even though that mothers may not be aware of the new baby is coming, and the heart already starts pumping. But the heart doesn't really finish the development until we start using our lungs, and that gives a very long period for any obnoxious event, virus or anything to halt that development and result in a congenital heart disease. And of course, compared to adults, that's only 1 in 10 patients with a heart problem would present with congenital heart disease. It's quite a lot, actually. And another notion of difference is that when you are dealing with adults with coronary disease, as we heard, you can do a successful investigation, successful intervention, and that person goes back after a couple of months to work and actually will pay back what society invested in medical care and so. For the babies, it's quite different because when you deal with a neonate, that takes almost like 2 decades that that neonate can pay back what society invested to him. So that's a long-term investment for future. And when we look at the congenital cardiac patient population, we can say that about 80% of them are below adulthood, 18 years of age. And that patient population is actually growing, that become so-called adult congenital heart patients, thankful to the possibilities that we can treat them. Now, in these days, antenatal diagnosis and detection of congenital heart disease is becoming prevalent, and more about 3/4 of the cases we can actually prepare for a better planning, how those babies would be born, and we can avoid all those horrible stories that someone is born with a rosy outlook for life and all of a sudden decompensates, and we need to rush into the catheter lab or the operating room to save life. When we see a neonate with congenital heart disease, they come with a normal maturation because the heart is affected, but due to peculiarities of the fetal circulation, actually all the body organs can mature, and those babies would have a very good outlook for life if we could do an operation, which they need around 55 to 60% of the cases during their lifetime, and 2/3 of those cases they would need surgery within the 6 months of life. Now, since the 80s, we try to fix all the problems with operations. So that's the unifying philosophy of our work. But unfortunately, that's not really possible in some of the patients when you have to go for stage repairs. But when we were discussing that this is a real life changer, these are what the data shows, that someone before congenital cardiac surgery had less than 20% chance to be alive at age of 18. Now this is more than 85%, even 90% in 2021. So that's a great changer. Most of our patients, as I mentioned, are either neonates or small infants, and we can do primary repairs of them. And then those operations are quite risky, unfortunately. When you look at the risk stratification, when we try to tabulate what those risks are, you can see that these 150 operations that we are basically doing in any combination of those 150 operations. So we deal with mostly complex or even most complex cases. Patients, they come in a very widespread age group, from a couple of hours of age even to the let's say elderly people around 60 or even more. They come with a different broad body weight from a couple of hundreds of grams to normal adults, and that sets a great expectation for the entire team and also for the patients to be successful. The statistics shows that there is one cluster of patients, neonates coming for complex repairs, coming for emergent acute situations. But the good news is that the results for those patients are not significantly worse. Actually, not too much worse than even 95% survival we can achieve with those patients when you compare to the other patient groups. That's definitely a good news. I would like to share one success story in our domain. This is a situation when you have transposition of the great arteries, when the two great vessels, they are wrongly arranged, and they are in a wrong connection with the ventricles. The one pumping chamber that pumps out the blood into the body is the right ventricle that basically pumping out the dark blood, and the other one is pumping out the blood into the lungs. So in one circuit we have just circulating very dark blood, and the other one is very, very bright blood. And if there was no communication, these patients, they wouldn't have any chance to survive. Now, for these patients, there is an operation when we actually change over or switch over the great vessels by cutting them through, and then taking the coronary arteries out of the places and bring to the new places, and then connect the aorta normally, aligning from the left ventricle, pumping out into the body the fresh blood, and then we will connect the pulmonary arteries. And these patients, they actually go through this surgery very, very successfully, and they have a new life, a completely healthy outlook for a good quality of life. This operation, when it came into the scene in the mid-70s, early 80s, carried a high risk of mortality, around 10%, but now most centers can do this operation without, let's say, significant risk. So that's really a success story. And most of our patients, in other operations, we can do the same intervention. When we look at the modern trends, we can state that the time of the primary operation can be lowered. So even we perform these operations in a much younger age, but the risk still remains slightly higher. So there is other possibilities to deal with the surgery. You can see this is the incision for normal or classical cardiac surgery, but when we are dealing with less complex problems, we can actually do a couple of more cosmetically appealing incisions. Or you can see this patient had a cardiac surgery, open heart surgery, but you cannot see anywhere where the scar is. This is a good cosmetic result for a lot of patients. Or we can do something else. And this is an example for that, when you combine with the cardiologist the work and some parts of the operation, the procedure they do, some other parts we surgeons do. And in this patient you can see the stents that connect the arterial outflow from the heart, and also some part of the venous backflow towards the lung. With that, I already mentioned that the grown-up congenital patient population is actually growing, and probably in the coming years will exceed in numbers with the babies. So for those patients, we need to come up with less aggressive methods like stents and some implants. Whenever we can actually combine the efforts from the team from cardiologists. And that actually signifies the point of my talk, that pediatric cardiac surgery is actually at the crossroads of disciplines, and requires a lot of teamwork, it requires a lot of communication. And when we are expecting that pediatric cardiac services in Singapore will develop, this is what we expect, that we can create something like a continuity of care, the patients coming from the community, undergoing their procedures, and they going back to the community. So that takes a great teamwork, and you can see the NUH team is very dedicated and devoted to realize that teamwork, that based on transparency, that the public scrutiny is actually looking at the results that the team and the service can provide. Now, just a couple of words about the future of our work. As I mentioned, this is still quite an aggressive work, and I hope in the future these very aggressive operations will be obsolete. We can do prevention, we can come up even much better, much smaller, much more advanced devices that we can put. And of course we hope that with new modalities like 3D printing that nicely gives you amazing, almost like artistic specimens and models of the heart, can help you to make cardiac surgery much safer. We also hope that with some robotics we can actually achieve that someday we can send robots in the operative field that will do the surgery that we are doing in the field of the virtual reality. So all those techniques will give a new possibility and opportunity for these patients to undergo these surgeries much less aggressive and much more safe. And of course, we hope that new materials will realize that I would say holy grail in congenital cardiac surgery, that we would have implantable valve that is living and is growing with the patient, and that will avoid the necessity that all those patients will undergo a couple of surgeries until they reach adulthood. So that will be the other half of that circle that brings patients to a new possibility to undergo. So I would conclude that congenital heart surgery really has life-changing effects. The results are ever improving. Work is very much based on a team effort, and we will see how the future will improve the safety and bring less aggressive procedures with the change of new modalities. Thank you very much.
Thank you very much, Professor Laszlo. I'm sure many of our viewers are actually wondering that right now to themselves. A neonate, a young child, a young person, a small human being, can they take a surgery? I mean, a surgery sounds very challenging to deal with.
Yeah. Some of these surgeries are really very challenging. They are not very, very short. But I would say that those little babies are really remarkable. They can take all these requirements so resiliently and so fantastically that we adults wouldn't really take them. We operated a little baby with quite a complex issue last week, and the patient went home, not only discharged from ICU, went home from the hospital on the first postoperative day.
Wow.
Really amazing.
The resiliency, like you said, absolutely phenomenal. Thank you very much for sharing with our viewers. Now it's time to open up the floor, as it were, to your questions. You've been sending them across via our YouTube chat. We've been putting them together and addressing them to our panel of doctors. The floor is open right now. You've still got time. Shoot off those questions ASAP right now to that YouTube chat. If you want it to go to a specific doctor, please just write their name there as well. Let's pick up our first question. Dr. Chai, it's for you. Our questioner wants to know, oh, don't forget, leave your name if you want. Then I can address the question to you as well. This questioner wants to know, what is the difference between invasive and non-invasive tests? Okay, let's clarify here.
Thank you for the question. I think that's a great question. I'm sorry I didn't make it clear. Based on the basic level, invasive test means that you need to insert something into the body. For instance, when we do an invasive coronary angiogram, we have to insert a tube into one of the arteries that go all the way into the heart arteries. A non-invasive test is a test that does not require anything to be inserted. All right, so generally it requires some kind of scans. All right, I hope that answers the question.
Follow-up question from one of our listeners. We mentioned calcification just now in your segment. This person asked, does taking calcium supplements worsen calcification? Great question. A lot of people ask this all the time, actually, Dr. Chai. What do you say?
Yes. There have been some studies that show that excessive consumption of calcium supplements may be linked to increased coronary calcification. But I think that the answer is still not 100% established at the moment. So generally, if you are taking calcium supplements, just take the recommended amount. Don't exceed the recommended amount.
So who's taking excessive amounts of calcium? They think that the more you take, the better it is.
Stronger the bones are, yes.
Okay, no.
So generally about 900 to 1,000 milligrams of calcium a day should be sufficient.
Yes, stick to your recommended daily allowance. Thanks for that question, everybody. Dr. Lin, this one's for you. Our questioner wants to know, what screening tests would you recommend for individuals with no symptoms and who are leading a relatively healthy lifestyle? I like that question, and I'll tell you why. It shows that this person wants to be quite preventive and preemptive about any major problem ahead. What options are there?
This is an excellent question, and I think everyone needs to think about this when you hit a certain age. So generally, we advise patients to go for general health screening even in the absence of symptoms. General health screening will include a questionnaire, a health screening questionnaire, some simple blood pressure tests, some simple blood tests to look at cholesterol levels, blood sugar levels, because all these conditions, they are silent, they do not have any symptoms, and sometimes the only way to diagnose them is to look hard for them by the family doctor, general practitioners. So yearly or once every 2 year health screening in someone who has hit a certain age but has no symptoms, I think that is completely appropriate. If the health screening shows out some abnormal results, or if the doctor is a bit worried about some of the things that the patient highlights, then a higher degree of screening, such as sending the patient for a treadmill test, some form of cardiac stress testing, or even a CT coronary angiogram, this might be reasonable for individual patients. So get health screening when you hit your age.
I'll add on something to that as well, because I think sudden cardiac death came up earlier as well. Maybe before a long distance run or a race, there are actually pre-race checks that one can go for as well, right?
Yes.
Yeah. Well, of course, in our mind, the first person to appear in our mind these days will be this footballer called Christian Eriksen. If you think about it, he is a multi-millionaire footballer. The club invested heavily in him, and he has gone through all kinds of health screening, but this kind of accidents still happen while he's playing football. Of course, health screening is very important for someone going through competitive sports like marathon running or competitive football, but it's not perfect. Sometimes we do miss things that doesn't show up on health screening. I think for a general population, what I recommended earlier should be sufficient. Blood pressure check, blood sugar check. If you want to go for higher degrees of sport, competitive sports, maybe consult your family doctor. If appropriate, they can send the patient to cardiologists for specialist input.
Follow-up question. Another questioner wants to know, Dr. Lin, the prognosis of diastolic dysfunction, is it as bad as heart failure?
Wow, this is a very, this is an excellent question.
I love your viewers. They know their stuff, actually.
Yeah, they really know their stuff. So diastolic dysfunction is a very technical term. I'll try to explain it in simple language. So the heart has two phases. systole and diastole. So systole is when the heart contracts to pump blood out of the heart to the rest of the body. Diastole is when the heart relaxes to draw in blood to fill up the heart again. So systolic dysfunction is very easy to understand. The heart is weak, it doesn't pump blood to the rest of the body. Diastolic dysfunction is really a very difficult concept to understand. But if you can think of a heart as a very pliable balloon, it relaxes very well, the blood goes in very well. But as we get older, or in some conditions where the heart muscles get very thick, the diastolic function of the heart gets impaired. When the heart relaxes, it doesn't relax very well and the blood doesn't fill the heart very well. Instead of going into the heart, the blood might stay in the lungs and the patient gets very symptomatic. So this is what we call diastolic heart failure in the past, but nowadays we prefer to use a new term which I spoke about just now, called preserved ejection fraction or preserved pumping function heart failure. So they are all heart failure. Patients present the same way. The unfortunate thing is that for this group of patients with preserved systolic function heart failure, they do not have good treatment. And as my very intelligent viewer pointed out, the outlook, the prognosis of this group of patients are equally as bad as those with very poor pump function.
Great question. Keep them coming in. The next one, Professor Tan, is for you. Our viewer wants to know, how long can a stent last? I'll add on to that as well. Can we choose our stents or not? No.
No, I would say that the choice of stent will be dependent on the operator. So the operator will choose the appropriate type of stents in accordance with the nature of your coronary anatomy and blockage. So people like to compare stents with bypass graft, because bypass graft with veins has got a 50% failure rate at 10 years. And so people also like to compare stent with graft and see what is the longevity of it. The truth is that it's actually quite a different concept here. So when you put in a stent, you basically treat the part of the artery that was narrowed. And like I say, if the stent doesn't get re-narrowed again within the short span of time between 6 months to 2 years, then the chance of it getting blocked again is actually very low with passing years. That's not to say that it cannot happen, but it is less and less likely as the time goes by. But what is more important here is that you have to undertake lifestyle and risk factor control so that no new blockages happen elsewhere in your coronary tree, so that you will require a second procedure. So by itself, the stent is fairly durable. The chance of success of a stent remaining patent is in excess of more than 95%, I would imagine, at least you can see from our data. But it is not the end-all procedure. It is just the beginning of a lifestyle and changes that you have to undertake in your own personal life.
I'm glad you mentioned that, because I'm curious, if you've had that first narrowing, does that mean that chance for a second one is actually quite high?
It is. It just means that you're predisposed to this condition, either because of a lifestyle or a genetic condition. So you need to go into this lifestyle and risk factor change.
Yes, it's a real wake-up call to make those changes. Here's another question for Professor Tan. This person wants to know about dealing with, imagine this patient has come in an ambulance, they're feeling the symptoms of that narrowing, they're in discomfort already, and you're doing this procedure on an awake, a conscious patient as well. This questioner wants to know, will the patient be able to feel any discomfort? I would imagine the discomfort they're feeling from the blockage is probably greater at that point in time, right?
You're probably right, because the act of performing a coronary angiogram and an angioplasty is a painless one. Actually, with good anesthesia and technique, the patients actually don't feel anything at all. So I would say that this is the beauty of this minimally invasive technique, and that's why it's being preferred to a more invasive coronary artery bypass surgery, simply because you can now treat the patient's blocked artery in a conscious state through a very small skin incision. So that is the real advantage of coronary angioplasty.
Actually, Dr. Chin, coming back to something you mentioned earlier on as well, the difference between minimally invasive and, are we seeing a trend more towards minimally invasive now? Is that the overall trend since we were just dealing with that?
Yeah, talking about
as procedures overall?
Procedure, yes. I think now over time, of course it depends on the patient's condition and so on. But I think now, because of the success of percutaneous coronary intervention, more and more people are opting for that. So, even in patients with multi-vessel coronary artery disease, however, it all depends on the patient's underlying condition, whether they have diabetes, heart failure, and so on. And the cardiologist will be the ones. Normally, it's a team. We have a team, like a cardiologist with a surgeon, to decide what would be the best treatment option for the patient.
In fact, minimally invasive surgery is the big direction in which medicine is heading towards. Because even our surgeons are now going for minimally invasive surgery instead of a very invasive big sternotomy. We are talking about small keyhole operations. So minimally invasive surgery is the way to go if it's feasible.
Professor Laszlo, is that an option for neonates?
Of course, it is. Probably not for neonates, but certainly these practices they derived from adult cardiac practices, and they are becoming more and more popular and feasible for babies as well. And as I mentioned, the biological aggression is too much. We have to decrease that burden for little babies. So these techniques, they will find their way of utilization in pediatric cardiac surgery as well.
I'm looking forward to that as well, because like you were talking a lot about the nature of the scars and growing up with that scar. I'm sure that is still a concern for some parents for their children as well, and this would mean much smaller scars eventually. Fantastic.
Absolutely. As you saw, the images are showed there are no scars visible for those babies.
Wonderful questions, everybody coming through. We've got one here as well. It's open to all. This person says, if you still have persistent chest pain, despite having a normal CTCA or coronary angiogram, how soon after should you repeat the test? Dr. Chin, let's come to you with that.
Yeah. If I have a patient that has gone through a coronary angiogram, say 6 months ago, and the coronary angiogram was normal, and the patient is still presenting with persistent chest pain, I think the first question we need to ask is the chest pain due to the heart? It may not be due to the heart, it may be due to some other condition, such as reflux or some nerve condition, right? So we have to look into that. Now, there are some conditions where patients can get chest pain due to lack of oxygen to the heart muscles, and yet the coronary angiogram is normal. Now remember that the coronary angiogram looks at the big arteries, the big heart arteries that run on the surface of the heart. Some people do get small artery disease, which we can't pick up on the coronary angiogram, right? So those patients do sometimes suffer persistent, repeated chest pains. And so for those patients, they will have to go through some specialized scans to look at the blood flow pattern of the heart muscles. And we find abnormal blood flow in the presence of normal coronary angiogram. That patient will have to be treated with medications, right? Okay, so the question actually is, how soon after a coronary angiogram can we repeat a coronary angiogram? I think the answer really depends on how long after, and whether there have been any changes in the patient's condition since the last coronary angiogram, right?
Needless to say, you will be closely monitored.
Yes, definitely.
Absolutely, great question. Professor Laszlo, this one's for you. We touched on this actually a bit in your presentation. Our next questioner wants to know, what is the life expectancy of a child with CHD?
Congenital heart disease comes with a spectrum of anomalies, and of course there are very, very complex ones, especially when you're lacking one of parts or segments or chambers of the heart. That gives you a different outlook for life from the ones when relatively simple problems. You deal with the hole inside the heart or abnormal arrangement of the great vessels, as I mentioned. For the latter cohort, we have an extremely good expectancy of life, almost nearing to normal. As I mentioned, the numbers are improving, and for a neonate, being born with congenital heart disease has an over 90% chance to reach adulthood. But it's more importantly, the quality of life is nearing normal. So I think in short, I think the life expectancy is parallel with the normal population, and quality of life is actually, again, approaching to the normal.
Thank you very much, Professor Laszlo. Many of you have been asking this question. We've combined several of your points into this one. Is there a higher risk of heart attack after taking COVID vaccination? This has been a hot topic on my radio shows on a daily basis. Many of you have been reading headlines and maybe just seeing the headlines and not really getting the full information. So let's try and summarize and give you the key points when it comes to COVID vaccination and heart risk. Professor Tan, if I can come to you with this, please.
You know, heart attack occurs in the thousands every day in Singapore. And so you could have a person that had COVID vaccine, because it's just a widespread thing now. happen to develop a heart attack or a stroke, but that does not necessarily mean that there is a causal relationship here. I think it's very important here. The causal link has never been proven. We have never been able to show that the COVID vaccinations itself can cause a heart attack. So I would say that at this present time, I say there's no concern with developing heart attack and stroke after vaccination. In fact, just looking at the overall situations right now, I think the risk-benefit ratio is still highly in favor of vaccinations than not.
Because we still know that people with a history of heart disease or at risk for heart issues are going to have worse outcomes if they were to get a COVID infection.
Exactly. Indeed. So if you have a heart disease and you come down with COVID, your chance of mortality is 10 times that of somebody with no background disease. So you are actually a high-risk group of patients when you have an existing heart condition. And there's no pre-existing heart condition that preclude you from vaccine. So almost every heart condition patients are safe actually to go for vaccination.
Dr. Lin, do you think that maybe people are asking this because they're also hearing about things like, warnings or risks being added to labels of certain vaccines and worries about myocarditis and things like that? So maybe not heart attack, but maybe other issues.
There is some signal coming from all the hospitals around the world with this link of myocarditis to COVID vaccination, specifically to the mRNA vaccinations. So we do have data coming from US, from Europe, and even local data saying that there might be a possible link, but luckily for us, the myocarditis cases that we see, even if they do occur, are generally very benign and patients recover very well. But if you look at the whole scheme of things, the number of patients receiving COVID vaccination, the incidence of myocarditis is still very, very low. Although there is a link, a possible relation, I think at this point in time, as my other speakers have said, the risk of complication is still very low compared to the need for vaccination.
The point of the matter is, go get vaccinated. It's very important. And if you're ever in doubt and worried about anything, speak to your doctor first. That's absolutely fine. I'm sure they're definitely going to talk to you. Another question coming in right now, does a person with low blood cholesterol, is that person still at risk of a heart attack? Dr. Chin, why don't you take this one?
Yes, that's a good question. Now, high cholesterol is just one of the many risk factors for coronary artery disease and heart attack. So it is possible for someone with low cholesterol, but who smokes 3 packs a day with badly controlled diabetes and high blood pressure, and that person can still get a heart attack. All right. So you also need to consider the other risk factors as well, not just the cholesterol levels.
And a follow-up on CT coronary angiographies. Next person wants to know, can it tell us the percentage of blockage if blockages are present? You touched on this. It can show that a little bit, can't it?
Yes. Yes. So we can, so most of the time we will visually estimate the degree of blockage, but we can also use computer software to very accurately measure the percentage of narrowing and blockage.
Thank you very much to all the questioners coming through. I'm sorry if we didn't have time to get to your question you may have left. We tried to squeeze in as many as we could. Doctors, thank you so much for helping us get connected today. Thank you for your time.
Thank you very much.
Thank you.
And thank you all for joining us on today's edition of the English Health Symposium. Get connected, the heart truth that does it for today's session. But don't forget, because this is on YouTube, you can watch it all over again and go back to your favorite parts as well. Thank you for joining us online today. Stay healthy, stay well, everybody. My name is Daniel Martin from MediaCorp on CNA 938 and Channel 5. Take care, everybody. Bye-bye.